Lunch is arranged in Alumni Hall for the National and Resource Faculty and the Yoga Hall above canteen for all the other delegates and participants. Directions are displayed and our team will guide you. We can
Good afternoon to all the panel members, delegates from all the different districts of the AP as well as other states, and we have 5 international delegates also in the conference from various other countries. So welcome to this insightful panel discussion at AP Meticon 2025. The topic is very crucial one, bridging the gap between learning and clinical competence. Are we truly preparing learners or medical graduates for a real-world clinical practice? So as medical practitioners, medical educators, we often ask ourselves whether our students upon graduation, that is becoming Indian medical graduate, are fully equipped not just with knowledge but with confidence and competence to face the complexities of the real life scenarios in the clinical settings. We are joined by distinguished panel representatives from a diverse cross-section of the health professions. It's my honor to introduce first panel member, Dr. Ravi Venkatachalam Garu, a renowned cardiologist and the principal Government Medical College, Srikakulam. He is founder and heartbeat of APME also. Dr. Venkatachalam Garu is the first convener of RCMET Andhra Medical College, Vizag. Sir holds UG and PG degrees from Andhra Medical College and pursued faculty development nationally and internationally. He is now working at Government Medical College, Srikakulam. Venkatachalam sir's dedication to the both clinical excellence and institutional development makes him a highly valued contributor to today's panel. Thank you, sir. Now I invite, it is our honor to introduce Dr. B. Devi Madhavi Garu, distinguished academician, public health expert and passionate medical educator. She is currently serving as professor and head of the department Community Medicine, Government Medical College, Vijayanagaram, Andhra Pradesh. Dr. Madhavi Madam holds MD degree from Community Medicine from Andhra Medical College, has pursued faculty development at national and international levels, including 5-week program from St. George's Medical College and teacher-to-teacher program, T2T program from medical educators from Harvard Medical School. With over 25 years of teaching experience, she has more than 50 research publications in medical education together. To her credit, she has led the multiple research projects under ICMR, NCDAR and NACO. She is a recipient of prestigious State Best Teacher Award 2024 and has held several leadership roles, including convener RCMET at AMC, State Task Force Chair, NTEP, and State Nodal Officer for the Family Doctor Program. Dr. Madhavi Madam has also served as President of IAPSM, State Chapter of the Andhra Pradesh Medical Educators Association also. Her unwavering commitment to community health and medical education makes her a truly inspiring presence today for our panel discussion. Thank you, Madam. It's also my privilege to introduce Dr. D.S. Murthy Garu, an accomplished academician, medical educator who currently serves as Professor Microbiology and Vice Principal Academic at Sri Venkateswara Medical College, Tirupati. A graduate of Osmania Medical College, Dr. Murthy sir earned his MD in Microbiology from Gandhi Medical College and has further honed his expertise through prestigious programs such as ICMR fellowships in medical virology at National Institute of Virology, Pune. And of course, he is also the member of T2T medical education program at Harvard Medical School. And he has accomplished his advanced course in St. John's Medical College, Bangalore. With over 2 decades of academic and clinical experience across several leading government medical colleges in Andhra Pradesh, Dr. Murthy Garu has contributed extensively to both teaching and research also. He has published in national and international journals including the British Medical Journal and co-authored book titled Applied Microbiology and Infection Control for Nurses. His insights into the microbiology and medical education continue to inspire students and faculty. Thank you, sir, for being here. Now it's my pleasure to introduce my colleague, Department of, he is also a physiologist. I am proud to say that. To introduce Dr. P. Satyanarayana Raju garu, an accomplished physiologist and passionate medical educator, currently serving as an associate professor of physiology, Andhra Medical College, Visakhapatnam. A graduate in medicine from People's Friendship University, Moscow, and MD in physiology from Andhra Medical College. Dr. Raju has contributed significantly to medical academics since 2011. A trained sub-lieutenant of Indian Navy also from the Southern Naval Command, he brings a unique blend of discipline and dedication to his academic role. He is also a faculty member at the Regional Center for Medical Education Technologies, RCM at Vizag, and then an alumnus of advanced course in medical education, St. John's Medical College, Bangalore. With over a dozen publications in national and international journals, including PubMed Index journals, Dr. Raju has received multiple accolades, including Best Faculty Research Presentation Awards at AP Medicon in the year 2019 as well as 2024 also, and an award in Physicon conference also. His deep insights into physiology and innovation in teaching approaches make him a valuable voice for today's panel. Now,
who will introduce you? Go ahead, sorry.
I think they will put a slide on this. So, sir, let us begin with our panel member, Dr. Ravi Venkatachalam, sir, who is going to bring us the clinician's perspective. Sir, I request you to throw some light on the topic of the beginning today, clinical readiness from a specialist lens. What is missing in undergraduate preparation?
I'm going to change off my question. Not fair. Question answer. But anyway, since you asked me, this is the issue that the entire morning we've been speaking about it. Are students competent? And the same discussion goes on in all teachers' fora, and we all like to hear the answer. They are not competent. That's what we always like to feel, that current gen is not good, we are good, and times have changed and all that. Okay. But I would agree with what Krishna Sheshavi has said in the morning. But if you look at the good things first, the current generation of students, graduates, are very good in theory, learning theoretical aspects. They're tech savvy, which most of the older generations are not. And that's a really great advantage in the changing world of education and health science. So that we should keep in mind. Okay, so coming to the negative aspects which Dr. Sheshav has pointed, which all of us know, they are poor in procedural skills, they are poor in history taking, in clinical examination and decision making. But if you don't mind, I'll just play the devil's advocate. If everyone agrees, okay, they're not thing and we should train them and they're not competent. And this has been shown in multiple studies, both here and India and also other places also, that the current generation, they don't have good procedural skills and clinical decision making skills. But I was reading in a discussion forum their point of view. So a few questions I'll say. Their question is, now how many people stop at MBBS? If you look at the current years of study, in my batch, I think at least about out of 125, 40 students are only MBBS, practicing or having nursing homes. But now hardly 2 or 3 get at MBBS. So why should I learn to be a physician of first contact and not going to practice? The question asked is, why don't you go to gynec posting? Sir, I won't practice gynecology. I will never be in a PHC. I have never been a lower resource. Why should I know how to deliver a baby? I will never give a vaccine. So why should I don't need to learn on how to manage a PhD. I'm not going to do a PhD job. My aim is to go to US or set up a nursing home or join a corporate hospital or become a cardiologist. So that is there. So I'm just throwing this point of view. Are we putting off too much into this that MBBS doctors should know these things? In my view, this is my personal view, MBBS graduates should be able to diagnose and manage common problems, which unfortunately our current curriculum, even the CBMA curriculum, is not focused on. Like they don't know how to manage a common cold or cough and they learn that only in the house agency, which is now not given the go by now. They should learn how to recognize emergency, give appropriate first aid. Because I may cover emergency, which is not my field also. But I should know what first aid to give, recognize emergency, give whatever immediate treatment, and refer to an appropriate hospital. So I think we should have a small shift in our focus of how we are looking at competency. But still, I agree. It's nice to know. For example, I like to know I remember my gynec and I ask questions. I feel very elated that I know what he doesn't know. But all I have to ego, but it doesn't in the real world. That fellow is never going to treat some face presentation or a beach presentation. So why should I ask them about low sits maneuver and all those things? So that is their and the reason why they are not learning practical skills, because are you assessing it? We always say assessment drives learning. But he himself was saying the clinical examination based on theory questions. As he was saying, eat cashew nut, then you saw bed number 20. What's the diagnosis? How you made your diagnosis? All the theory which can learn from YouTube and learn. You're not assessing that. Your need does not assess practical skills. So why should I learn practical skills? Why should I learn something which I don't need? They're practical. So let us not be too idealistic. I'm really playing devil's advocate. I also feel we should learn everything, but maybe we should. I'm too old to change, but I think we should change our mindset and look at it differently. So that is my perspective. But I really feel that they are not adequately competent as basic. That's why they're afraid. They don't have confidence to even start anything. And the house agency is not helping because they're using house agency either to prepare NEET or even again the same department is not helping that. What does the house agency do in the department, many departments? They get the reports or arrange blood transfusion or take the patient, get the ultrasound scan done first because you have to push to the surgery. Because you now have so many PGs, the house agency will never get a chance even to assist, be a third assistant. You have 20 PGs in surgery, each table has 4 PGs. The third PG will be catching some, the second PG is gone or preventing falling open. So what chance will the house agency get?
Sir, at least our expected next two, that is next second component of next, which is on purely on clinical component to assess clinical competency at the end of house surgery, that may help a bit.
Who will assess that?
Again, our teachers only, sir.
So, morning he was saying Harvard, he was shocked that 90% pass. Who passed them?
Our teachers.
Students didn't pass them. The teachers passed them. So whose fault is it? So why should we find fault with the students that they are not learning? You are passing them. I don't want to become bad. Well, let them fail in theory, I'll give them here pass marks. And that also what pass marks they are giving now? 60-40. He may get 40, they'll let me give 60. At least I'm not giving 40 and we will give pass mark and leave it there. And then anatomy, what they do? They unfortunately, their paper is 150 and 200. So they give it 30, they give 70. Because unless they give 70, that fellow won't get total 50. So we got to that extent of facilitating pass. How can we blame Harvard people and say that fault is in teachers?
Sir, to conclude,
Next two also will become teachers.
Your part, we need to blame our teachers only.
Ourselves, our teachers are good. They failed. Now naturally half the people passed.
Our teachers means our group of teachers.
We have to blame ourselves. I'm not saying fail them, but be fair and pass them with a deserved pass. So don't pass a person who doesn't deserve pass, and then you go out and say they didn't do well, but I had passed.
At least they will acquire the core competency which is required on this basic skill like blood pressure recording in first time.
Whatever it is, you assess them and they can't do that also. You're saying no. Fail them, they can't do it.
Definitely, sir.
That is my feeling. You can take questions from the audience also in between. I don't mind their feeling.
And then we will take the questions from audience also, sir. We will move to the second panel, sir. Second panel member, Dr. Devi Madhavi Garu, public health expert. Madam, as we know, competency beyond the clinic. As far we are discussing clinical skill up to the clinic, but beyond the clinic we have community-based learning and its real-world relevance. Is that FAP program or other programs of our CBME, is it good enough to make our student to face the community as a whole?
So at the outset, I'd like to thank all my mentors, teachers and colleagues and dear students also who are here attending this session. So basically, please remember for the students, so here whatever we are talking is more for introspection and for take-home messages for the teachers. Okay? So we'd like some inputs from the students also because the program important stakeholder is you. With that in the background, I'd like to just answer your question. So when we are talking about clinical competence, its extension into community-based medical education, whether it is more applicable to make them clinically relevant. Yes, definitely I think so, because as you say, in our definition of who we want an Indian medical graduate to be, we say he should be competent and relevant to the local needs. So that relevance can come when he becomes a humane doctor, not just a trader who treats disease. So this humaneness comes when he looks at an individual in this complete fabric of his social determinants of health. So when he steps out into the community, that helps him to get an opportunity to learn things which are often we associate only with clinical exposure. Like for example, observation skills, listening skills, and also like prioritizing, making community diagnosis. And here I'd like to just have one bit of a discussion about what Dr. Venkatachalam sir said. He said, now no student is going to stay with, or most of the students will not be staying as MBBS students. In statistics we talk about the probability. We are not sure which is the student who is not going to stay.
Nobody.
No, they would say that, but we never know at the end who is going to be that student who will be staying only as MBBS.
Nobody will say MBBS.
No, they will, sir. Some of them have to.
Because they want me to see it.
See, yeah, so that's what. See, like, okay, just because now you have auto gear cars, you'll say you will not learn a gear car. There may be a time where you'll need to use one. Gear car? Okay, manual car. Okay, so then that will put him in a tight spot someday.
Okay, sir.
Okay, so anyway, so coming back to what I said. So like, I'll just give some examples of what I have found
Yes,
the
ma'am.
students
Please
in the community. So first year students in the family adoption program, I was so happy when I saw an image of a girl who was holding an elderly woman's hand and consoling her because she was a single lady, 80 years plus, children had abandoned her, she was staying alone and she was having her general chronic polymorbidities. So, she was crying and this girl was showing empathy. So that is a skill you expect as a core competence for any medical professional, and that can be learned in the community and it comes spontaneously. Another two examples, these are all examples I say from the field where I have observed the students. So there was one lady who was having, she had a cataract, and then the student identified that she had a cataract and he was motivating her to go to the hospital and she denied. She said, I am afraid I am going to stay like this only. So it puts in, but of course this student I was talking about is only a first year student. It was a challenge for him. Seeing experiences like in the hospital you just say cataract patient gets operated. But these sort of situations, real life situations where they have to take on a bigger role of motivating or explaining, these can be done in the community. So next, some more things they learn is how the healthcare system works. These students are the physicians of first contact are supposed to be conversant with the healthcare system of the country. So when they're conversant, then they realize that anemia is the common problem when they go into the community, and they first look out for anemia whenever there is a patient who comes with general weakness and fatigue. Otherwise, with as we said, with the ChatGPT and other sources, the cause for fatigue and weakness can be very uncommon things which may pop up to them because of their lack of exposure. So listening skills, communication skills, team building also is a lesson they learn when they go into the community. So that is all a part of it. So it really provides an immersive learning experience. And I would like to say here, this community-based medical education has been taken up and advocated by many countries across. We have good examples, not only from the West, which we, as Dr. Krishna Seshadri said, we always mimic the West, but countries like Bangladesh, Indonesia, even neighboring countries, Netherlands, Belgium, Europe, all of them take up. So community projects can be given to our students where 3 or 4 people together can identify a common problem, identify a solution for it, and what can be done. So such sort of things have been done in other ways. For example, our FAP is a very well planned program, but implementation challenges happen to be there. So here I think the faculty role is important. One thing I think which all faculty should learn is, before we send our students into the community, we need to set the objectives of the community visit and then teach them the demonstrable skills. I say, see what is the prevalence of hypertension, go into the family, assess their blood pressure. But if the student does not know how to record blood pressure and I send him, then it becomes like, safari, where he's harming the community rather than this. So the faculty responsibility is teaching them, setting objectives of what is to be learned in the community, and also assessing them after they come back. So that is the main thing. Pre-briefing and debriefing is what they need to do. And feedback. When there was one more example I'd like to give. So one student, again this was a first year student from GMC Vijayanagaram. One day after our first visit to the community, she came back so excited. And she said, "Ma'am, I'm so excited." I said, "What happened?" So she said, "I went to this house. There was this teenager. I tried talking to her about her family. So initially she said, nobody is there, I'm only here." And she was not very reluctant to open up. But then this girl sat with her, chatted with her, and then she opened up and she told her mother had a fracture and that was outcome of a domestic violence. So these sort of things, like the student was excited that she could get the elicit, and then because she told us, you take some action, follow up. So these things can happen only if there is a debriefing session and sharing of experiences. So this is how we can improve the skills.
Madam, you have given us some confidence on the other side. You're going in the side that teachers are to be blamed for every reason and all, for competency of the student. You have given us some confidence that they are ready for community.
Yes.
Now I will ask my colleague, physiologist, are we bridging the gap between basic sciences and clinical relevance or clinical reasoning, critical thinking? I request Raju sir to react on it.
Yes, sir. So very good afternoon, one and all. So Venugopal Raju sir was asking question, bridging gap between these two. Primarily, medical education is a structure where we have preclinical phase where we introduce them with the basic subjects, and a clinical phase where we introduce them with clinical postings right from the second professional year. So often students, when we teach them in the first professional year, they frequently ask me anatomy, physiology or biochemistry, why do we have to take all these subjects in, should we memorize all that or no? Normally what we tell them, you have to take an understanding of all that so that you can give a proper clinical reasoning in the future. So if you have a good understanding of a preclinical subjects, this clears a gap when you go into the clinical options. So to consider generally, no patients normally when you are in the field or in your practice, never a patient present to you with a diagnosis. Although we have the AI system these days, everybody Googles, I have cough, and they get first option is cancer. But that is not the option here. So students should understand how and what subject presents with, what are the symptoms, and he has to gather all the information and then get into a proper diagnosis with all the understanding he has taken for, with a proper understanding of all the physiology and the pathophysiology behind it. That is what we clearly ask them, the students, to understand. If there is some patient presents with some chest pain, in anatomically, we normally teach them everything about any kind of thoracic anatomy and all that. He should understand that if I have a chest pain, it doesn't only mean I have a myocardial infection. It means that he might have esophageal rupture, he might have some other conditions like dissection of aorta and all these things. And more far from this are more relevant examples like why do we give certain investigations to some subjects? For example, I have asked a patient to get serum electrolytes. Why do I ask him to get a serum electrolytes test done? So for that, I should await the results because I have seen the subject with any kind of cardiac arrhythmia. Now what do I expect behind that? Any potassium or a calcium abnormalities? For that I should know proper cytology, proper action potentials, membrane potentials and all these, so that I wait the results and so that I can treat it properly. So this is all. In conclusion, what I want to tell you is basic sciences or the preclinical, paraclinical subjects really give a proper reasoning for whatever you're going to study in the future or the patients. You have to intercept them properly, connect everything together in order to have a better understanding and convert the clinical, all this knowledge into wisdom for a better future.
Thank you. Now I request Dr. Murthy garu to give his perspective on how the student is prepared and ready for lab to bedside, for the conversations from the lab, the conversation to the clinical arena, clinical encounter with the background setting of the lab area.
Yes. Good afternoon all, and I thank Dr. Venugopal Raju for including me in this panel. What I am going to speak in the next few minutes will apply not just to microbiology, but also to other diagnostic departments as well. But microbiology particularly, there is some problem because we grow microbes what are sent from the patients. Okay, so we have to grow them and report. So before I go for how we can bridge the gap, I will tell few things problems which we commonly face in the laboratory. For example, one intern comes with a blood culture sample, reaches the microbiology laboratory, gives the sample in the microbiology laboratory and asks, when can I get the report? Is it possible by tomorrow morning? This sample belongs to one VIP. So because the problem comes, he doesn't know about the turnaround times. And one sample we received in the laboratory with urine culture for Coxsackie virus. We don't do Coxsackie virus culture in microbiology laboratory from urine, right? And the other thing also, the problem from students as well. Not the below average students, I am speaking about what we consider the very good students who get distinction in almost all subjects. In one of the way I asked him, what is leptospira? What is leptospirosis? Is it a bacterial disease or anything else? He simply told it is a fungal disease. Why he thought leptospirosis is a fungal disease? Because that is a long filamentous structure he has seen in the pictures. So where is the gap? We always consider the students are at fault. But what I can say is the teachings are at fault, not teachers.
Sir, you have one more person saying teacher is at fault.
Not teachers are not lesser.
Oh,
the way we teach is at fault.
Okay.
The methodology is at fault. So over so many decades, we focused the microbiology teaching as whether the organism produces glucose, gas from glucose, or nitrates are reduced or not. All these biochemical reactions we focused more. But we should understand as teachers that the perspective should now shift towards the clinical application of this knowledge. For example, if I say Staphylococcus aureus is coagulase positive, I should be able to convince the student that why it is important. The coagulase, how it is important in the pathogenesis. Are we teaching like that? We have to introspect ourselves. Don't teach unnecessary biochemical reactions. That is one thing. As Sir aptly called, can we bridge the gap? If so, how? It is possible. We are always blaming the students. We should change our mindset first. We should introspect and examine how we are teaching the microbiology. Are you giving any, suppose if any microbiology faculty are there in this group, please examine yourself. Are we giving any problem-based learning to the students? There is a subtle difference between case-based learning and problem-based learning. Are we utilizing the problem-based learning in the way it should be used? And are we adapting that problem-based learning to advance the learning to the case-based learning? So these things we should examine. And also, I worked in Nizam System Medical Sciences for some time. We used to go to the patient's bedside and the clinicians will ask, the report came as sepsis with Klebsiella, the patient looks in a different way, how it is possible, is it the real pathogen or not? So that means the clinician is interrogating the microbiologist so that microbiologist has to answer it. We can mimic the same scenario in our classrooms. We can give a case to the students and tell that what are the possible organisms in the sepsis and how can we explain the reason, what tests you can do. Like that we should modify our teaching. Our teaching should change from the rote teaching like suppose morphology, lab diagnosis, culture. From that we should shift the scenario towards case. And two more things I will add, sir. Another thing is, one is, like I said, bedside clinics, we can include microbiology quiz also. For example, after your class, give a question to the student. Suppose this is a case you have discussed today. What are the mimics of this case and what are the mimics of the bacteria that can cause a similar condition? They will go and read and come next time. These things. Quiz also can include at the end. So these things you can, I think, these are only small things because so many are there to bridge the gap, but we can go ahead and discuss further.
Thank you, sir. Now we'll go back to Ravi, sir. To quickly
You didn't tell me yesterday. You are hiding question and telling no, ask me.
Sir, give a sentence of reaction on how do you think that clinical mentors can build competence without overwhelming the student, without putting load on the student? Can we train for the competencies? Mentorship can help it. We know that they are lagging behind.
The problem with mentors is mentor will be in his own subject. So I don't know, suppose I'm a mentor for 3 students in my college. I'm a cardiologist in medicine. So he will be phase 1, phase 2. It will be little difficult for me to train him, but I can help him to guide him how to wait to the thing that maybe mentor can help. I agree. But if you can permit me to add, can I add a role teachers can do?
Yes, sir.
Okay. I think teachers should teach honestly and as I said, use a CBME curriculum as it should be. Now even though we implement CBME and we know how to do it, we got trained, as far as the many places, old thing only continues. We don't really teach the competencies. I'm still teaching the same lecture and PowerPoint. In fact, my people don't like small group teaching. They said, sir, I have to give 120 lectures in this subject. So they don't like this discussion and student. They want to give lectures and be fair in assessment. As I said, pass them if they deserve pass. Otherwise, it's only 1 month away, supply exam. See, if they really is going to lose his, suppose his 4th attempt in first MBBS, I'll also be very lenient. In fact, we'll try to push him because otherwise he'll ruin his career. But fellow is going to again pass in 1 month. Why are you so worried? He's not going to lose a term also. Like I studied in 6 months, the referred batch. He's not going to do that also. He's going to join his main batch happily. So why should we worry about that? Let him write the supply exam and help him there. At least let him know that, okay, I won't pass. Let them do the assessment strictly. Regarding mentor, you want to say something? Yeah, please go ahead.
Yes,
Yeah,
please,
please.
sir.
Yes, sir, always says in the medical education meetings, there is 2 kinds of assessment, norm reference and criterion reference. We should change our assessment method from norm to criterion reference. I think then...
Or at least change the norm from 97 to make it some 80%. Okay. Second thing is this small thing about this mentor thing. Not exact mentor, but we used to do a cardiology summer observership. So, because they don't get posting in cardiology, we used to ask people who come for vacation to Vizag or when we was working to come for those 10 days to come to cardiology and just observe. They just observe and they shadow us. They go to the EC technician, come to echo room and all. We teach them as well on the road. We don't have any specific classes for them. But at the end of 10 days, they're so excited because they're involved in it. We make them write the discharge OP tickets and make them do everything like a real involved thing. So they like that. So I think we should let them be involved in the thing. If you see nurses, they are not hesitant when they pass the BSc nursing. They happily take up a job in Oman also and go and work there. Our fellows are afraid to even put up a clinic and see a patient also. Why? The nurse from day 1 has the hospital duty. She does bed making, then she does, so she's great in something. Why can't our own students be posted in the ward, not for classes? The stupid class takes only half an hour. 9 to 12, they wasted time. Who will come and take the case and they sit in the room and all that. Let them stay in the ward and let them take the patient and get the ultrasound done. Why should the house surgeon do it? Let the first year or second year do that. Let them talk to the patient, give them tablets like the nurse. Let them be involved. Then at the end of 2 years, see, aren't our PGs after 3 months getting the so-called entrustable professional activity? In 2 months, anesthesia PG is able to do his night duty. Till then he shadows. In 2 months, he is able to do night duty, at least in medical side. In 2 months.
Going for DRP also, sir.
DRP. No, DRP is again another big story. See, the NMC is very good. Unfortunately, we don't implement it properly. So, if the first year students, you post them for at least for 3 hours, let them do the hospital work. Let them have the class. I'm not saying no. Let it be from 1 to 2. Let that fellow see the case the previous day. Why should he see the case only from 9 to 12? If you do that, they'll get a lot of practical training. I hope Sir Shivan sir will please convince the NMC to change the schedule and let them have like nurses, sir. Let them have the classes.
Madam, how do you see this alignment,
classes.
madam?
And so here I'd like to say, the student doctor program is that only, no sir?
Where is it being implemented? And there only one case. No, only one case. No.
At least
I see
that's
only
a
2-3
beginning.
cases. No, that's not a beginning.
Beginning at least, that's a beginning, but that also we are
That
not
also
able
no,
to
you
do.
know.
So when we are
Not
not
doing
able
that,
to do
correct.
that, maybe it's too tall an order to think that they can spend hours in the hospital. So this at least should have been a change.
I agree.
Madam, can we extend this alignment not only for LDM or SDM? Can we go beyond this and align them to the clinical competence in real world scenarios? Can you do anything better than this?
So like I personally think the competencies which are there are actually in alignment with the clinical scenarios, what the common health problems or whatever. It's the methodologies as has been rightly identified by all of us here, that we are still doing only the old method of curriculum training. So that it is for us. See, I would say in this hall, this panel discussion is actually redundant because most of the people here are medical educators. And they are the ones who are already passionate about it, they are the ones who are adopting it. For an institute like a state where we have 30 medical colleges and minimum of 103,000 faculty, if they still are following the old things, they're not able to implement the CBME, that is the gap, that is what is there. So if we are able to implement CBME the way it should be done, I think we'll be able to get the competence. Okay, don't rush bringing in too many changes at too short a time, but given time, the faculty orientation should be done in a more different way.
Yes, madam. Now I'll ask Dr. Raju to add on this to this. How far the case-based discussions are helping us and our graduate to be more connected to the real world than to the classrooms? Case-based scenarios are.
Yes, sir. Obviously, when we take a subject in first professional area, we are doing something called early clinical exposure. We are exposing them with different case-based learnings so that they will tune up with that cases and then get back to the physiology and pathophysiology of that subject for a better understanding. So this stands as ideal, the case stands as ideal so that he can read around the subject for a better understanding. And problem-based learning or case-based learning is already started in the first professional year, like using early clinical exposures classes, and we are obviously using this vertical alignment theory concept with the medicine faculty and all this to introduce different diseases whenever it comes to applied aspects in the
How
subject.
can we make it more effective? Because morning session is all about we are
So
not effective.
making more effective is by small group teaching. That is the only way we can make it more effective. Like abroad, when we have 15 students, one teacher in the ward, that is more effective when you have a case-based discussion. Likewise, if I have 250 students over here, I introduce a case, none of them is interested. Might be first 2 or 3 rows as they listen to my class. Obviously, are always listening. Whatever nonsense I talk, they'll still be listening to my class. Okay, so the others, eventually I need to attract all of them with the amount of inputs I take. Either I learn to teach them. That is the way I interpret this.
You probably have a doubt. This case based is real case or paper case?
Paper case, sir.
Case
So
or
again you're going back to teach him in the lab. What he'll go and do in the real world?
No. That's what we are saying. Bedside with a small group
No, you're
teaching is
teaching
more
again
advisable.
problem again. How will you teach him how to see the blood pressure and whether how can he take the history and that is the
Sir.
problem. How can he give
Sir,
injection?
based on the student strength, now 250 students, we can go in one single go to the EC or hospital setup so that they cannot handle us. The patient load and the student load now 500 to 750 students, when compared to the previous days. So that we need some amount of discussion based on case-based or clinical scenarios as implied by our medical education also. Now I request Murthy Garu, sir, what about interdisciplinary teaching or integrated teaching to complement and fill the gap between real world and what is happening in the classrooms?
Yes, sir, it is definitely possible and can be implemented. First thing, I simply start with a simple example. For example, when I am teaching about antibiogram, and we can involve pharmacology people. So we can have an interaction with those people, and we can give a problem to the students. We can say, suppose in this particular case, this is the antibiogram, and some are sensitive, some are resistant. We can ask the students to work out which antibiotic is particularly suitable in this particular scenario, and what are the pharmacokinetics of the drug, what are pharmacodynamics of the drug. In that way, we can utilize the service of the pharmacology and we can have interaction. In the same way, we also, suppose we are going to infection control, microbiologists are supposed to do infection control rounds. When we are doing infection control rounds, we can involve, suppose some medical students are there in that ward, we can take them along with us, we can tell them what we are observing, how they are discarding the biomedical waste, where they are discarding, how they are disposing the needles, how they are cleaning the surfaces. All these simple things we can do while infection control rounds itself. No need to take a separate class in the classroom. In the same way, most of the times the microbiologist report will be better utilized when it is converted to treating the patient. And most of the doctors fail to utilize the report because they don't understand the antibiogram, they don't understand the role of MIC or whatever it is. We can, suppose we can teach a class on that, we can make the students as a duo. One student will be acting as a physician, other student will be acting as the microbiologist. This clinician will be asking the microbiologist, why I should use this drug, why should he be not using this drug. This microbiologist student role play, he should be able to answer it. Like that, we can create some groups in the students, we can make the microbiology teaching more interactive, more interesting. We are the bosses for our class. We can utilize the classroom as our arena. Your goal is to teach that topic.
Can we ask people from other departments to join into the...
Definitely, sir, definitely. Pharmacology people can definitely join, surgery people can join.
Will they come if you call them? Will they come if you call them?
Sir, sometimes they will come, sir. Many times they fail to join because they are busy in their wards. They should also be convinced, because maybe from our side, we should be able to convince the clinician the importance of the topic. They also join and make that discussion fruitful to be useful to the students, later to the doctors. Most of the times I used to go to the pediatrics department and have some interactions there.
Okay, now we'll ask some of the audience opinions also. I request one of the volunteers to take the mic to the audience so that we'll take 2 questions very fast.
What questions? Who will answer them?
Your panelists are available from different domains. I'm requesting for questions only, not comments.
A short comment. It's comment, short comment.
So we have panelists from different domains, so we can ask a question, sir. Sir, make it precise and clear, sir.
Sir, I will add a couple of comments, actually, brief.
Plus, sir, please introduce yourself.
I am Dr. Srinivas, Associate Professor in Department of General Medicine, Ashram Medical College. I actually work for the...
It is a planted question, huh?
No, sir.
Not anything fixed.
No, sir. My first question is, I am going to support you, Dr. Venkatachalam Garu. It is actually across the globe, if you go into the history of any education system reforms, without bringing transparency in examination or evaluation, none of the intervention will succeed. It's a history. All the countries. So, if you are not having any guts to conduct an exam fairly, that means that we are going to get the same result. That means our intervention going to fail utterly. That's a fact. The second thing is regarding Murthy Garu has said about the method of teaching. And actually, I just add one point. This is actually a method of learning, sir. most of our students are coming from the private schools. They are being tutored from LKG to the 12th standard. They have never been exposed to science experiments. The method of learning is rote learning, only the by hearting or doing some MCQ, solving the things and all. First time they were being exposed, and most of the children, maybe 95 to 98% of the children, first time only after coming to the medical college they will operate the microscope. So their way of learning is only reading and this one, sir. We need to, actually these people don't have the professional skills that are required for the self-learning and to become as a professional. So I think our modules needs to be changed as per our requirement. So we need to teach them how to pursue the textbook and all. The last point is, I will finish it off. And the last point is, a simple example with comparison with the schools, that schools also have the CCE model, like continuous comprehensive evaluation, like our CBME. In that, they have a set of goals that are prescribed in the 2010 itself, like NCRT and HCRT. Like 8th class students supposed to listen the 15 minutes of the English cricket commentary in English, and he has to brief it in 5 minutes in English. That's 8th class standard. But none of those aims or objectives were included or tested in the 10th class exams or 8th class exams. So even after 15 years, their level is the same like that of before 2010. Similarly, the CBMEs, these objectives or aims were not included in our university exams or in essays. So definitely we are also going to fail like that of CCE model in schools. Thank you.
Thank you, sir. A quick response from Ravi, sir. No response. Okay, sir. Now, please pass the mic to the madam in the third row. Ikkada, madam, third row.
Good afternoon, sir. I am Dr. Raghunandanan from Madras Medical College, recently retired as Professor of Medicine. I think the debate revolves more of summative evaluation. I think the NMC has given a lot of scope to do formative evaluations. So I don't think we have to blame anybody. We have to blame ourselves. Because suppose in medicine you have got 7 units, so each unit will get around 6 to 8 students. So there are certifiable skills in the final year. So I think whatever the NMC says, there is a lot of scope to ensure the learning process. The problem comes in implementation for many reasons. So I think we have to address that issue which prevents us from implementing.
Thank you, sir.
I am Dr. Kavita,
Yes, ma'am.
Convener Regional Center, Madras Medical College. The biggest challenge that most of us are facing who have 2 students is, at the same time, as sir said, that 3 hours of clinical teaching is becoming an extended lecture classes. But where do we accommodate them into the clinical teaching within 3 hours? Maybe 60, 80, 90 students in second year, third year, final year. How are we? I would like to know how others are also managing that. The number of students in that 3 hours from each of the year, where do we accommodate them and do the clinical teaching? Medicine, surgery, OG, pediatrics.
Yes, sir. Please respond. You can react.
At a time, your department will have 3 batches, madam.
Yes.
Maximum 3. Usually
Yes.
2, sometimes 3. So what is happening is, the junior most batch is usually taught by the PG, the third sem person. Is in the morning, what happens in my college is, 9 to 10 they have a common class for where they teach them about theory parts and history taking, patient profile and all that. The next the so-called practical clinical class is taken by the PG for the third semester, the second phase of DBS. The SPM going batch, the micro going
Second year.
Sorry, SPM
third year.
going batch, the third year part 1, they taught by the assistant professor, and the medicine exam work is taught by the professor or assistant by rotation. Only on the post-op day they have a difficulty in teaching, so that day they leave it and just follow the rounds. So 3 people, we have 3 faculty in any unit will have 3 faculty minimum.
NMC doesn't address, and again it becomes a larger group and they don't see the patients and patients are not being seen by them. In the OP.
Madam, as per NMC, you won't have more than 8 students in unit in medicine, surgery, gynae. You will have the problem happens in ENT, ophthalm, DVL and psychiatry. So what you should do is you change your posting in such a way that what we are doing is, like suppose psychiatry is 2 weeks posting, DVL is 2 weeks posting. We are borrowing something else from the next term. I mean, this is all local adjustment. So when you have 2-week postings, your entire the batch is going to medicine. Like suppose 40 students go medicine, 40 will go to psychiatry plus DVL plus radiology. So again you get only 12 or 13.
But if it's going to be those students only in that unit attending, then only one day they will attend for one admission day to the OP. So the rest of the days they will not be attending.
They go to the ward madam, they take a class.
Directly they will be going to the ward.
Okay.
Thank you, sir. Thank you, everyone. I think one last question from Somnath Das, sir.
Somnath sir, GSL. Sir, actually, the competency based CBME says that competencies with high criticality are most important for the students when they come out. But and for them, that it should be a small group learning rather than a large group learning. For small group learning, it needs definitely a lot of main power. And our main power, the professor will be one, but down below will be more number. Means assistant will be more and SRs will be still more. So we have to involve those people, particularly including the postgraduate students. But what NMC says that the BCME should be above assistant professor level only. So what I feel that it should be, unless they are taught how to teach, they are not the proper people to manage a small group learning. That's what I am thinking. So there should be something like senior residents and JRs has to be given training on the BCME.
Agree. We can take a short course on educational technology for them.
Yes.
Like some of the institutes, JIPMER has the same MEU training for PGs also. I agree, yours is a valid suggestion. We can take with the SRs and PGs also a session on the MEU can conduct that and train them. I agree, totally well taken.
Sir, CBME is rolled out since 2019, sir. But till now also it is there in dilemma. Means where to keep Aptha ENT in which profession, whether it is third or fourth. Till now they are not confident enough to finalize the whole strategy.
That's again because of us only. Us means politicians. They are not allowing next to happen.
Exactly.
Thank you, sir.
और अफसोस की बात है कि आपकी सब्जेक्ट तो है ही नहीं विवेश में.
So one line from Dr. D.S. Murthy to conclude.
Actually, sir, in the process of learning, we are learning along with the students. We should understand that. And also, when we are playing the ladder of learning, we should also learn to unlearn certain hindrances. Unless we unlearn and we shed some fears or some inhibitions, we cannot really see the beauty of the real learning. So this, I think, this has multiple meanings. I think you can reflect on that. Thank you.
Thank you, sir. Thank you, the panelists and the audience also. Let us strive for in such a way that our medical graduate is not only knowledgeable, he is also confident for clinical skills for tomorrow's physical abilities and clinical encounters. Thank you. Yes, he has to or she has to treat me and all of us tomorrow. And Venkatachalam sir also tomorrow. Thank you one and all. Thank you for your patience.
members to present the certificate to a moderator.